The medical community has introduced new ideas and put forward some of the most unique cures in the history of mankind. Isn't it time that this information be found in one simple and easy to get to place? Introducing Stayin Alive with Dana Hammill. Dana has been in the medical community for over 15 years and is ready to bring the latest and greatest in the medical community. Each week, Dana will interview different doctors in different fields and will offer you, the public, to call in and ask questions that you need answers to. Call into the show, 888-565-1470, and feel free to ask the doctors any questions that you may have. All shows can be seen on amp2.tv or the wwnnradio.com website. Now, it's time to get informed. Here's Dana Hammill.
Good evening. My name is Dana Hammill, and you are listening to Stayin Alive, the talk show designed to bring you the latest in what's happening in medicine. Tonight, we have a great show lined up. We'll be talking to Dr. Jonathan Hirsch, renowned orthopedic surgeon and sports medicine specialist, who can be found on staff at West Boca Medical Center. Dr. Hirsch, welcome to the show.
Hi, thank you.
I understand that you recently have a very cool connection with the Delray Beach Open. Can you tell us a little bit about that?
Sure. For about 10 years right now, the Delray Beach Open, which is a men's professional tennis tournament here in Delray. I've been the medical director of that for about 10 years, and professional men's tournament, it goes on for about 10 days. So it's been great. What
does a medical director do exactly for them?
Well, they require a physician to be on staff at all times. They require a doctor to be on staff at all times. So I'm there most of the time, and I'm responsible for the medical coverage and making sure that they have medical treatment during the tournament, nights, weekends, even when they're not playing.
What's the most interesting injury or situation you've had happen with them?
Well, we've had bee stings, we've had some stomach viruses, everything non-orthopedic, and broken ankles on the court. A lot of what they have is something they have had chronically. So most of what they use they have overuse injuries. So they come to the tournament with an injury that may be plaguing them for 6 months or longer. So the medical directors around the world, we all communicate with each other electronically to try to manage their problems ongoing, because they're rarely home. They're always traveling the world.
Oh, gosh. That's very cool that you're able to actually talk with doctors that have been seeing them and understanding, what the situation is, and they're able to treat it while you're there.
Yeah, as they travel, we try to communicate with the next tournament, because they're just going usually from tournament to tournament, and they have a very small off-season in the winter.
Do you get any of the inside scoop or gossip while you're hanging out?
We do. We meet their wives and girlfriends. We try to keep it very professional, but I get to know them. Some of them live here in South Florida, so they become my patients. When they're home, they text me nights and weekends, even if they're halfway around the world, for advice about what's going on.
Nice. What made you decide to get into orthopedic surgery? I mean, it's such a specialty, and when you were deciding what you were going to be, how did you pick this?
Well, going through med school, I kind of decided pretty early on I wanted to be a surgeon.
Okay.
And that's a sort of a decision you have to make at some point, separate whether you're going to be a medical, primary care kind of doctor or a surgeon. So I became a surgeon that wanted to become one. And orthopedics, I gravitated because not just from the sports, it was really more trauma first. When I was a resident, I worked at Bellevue Hospital in New York City, going to NYU Medical School. And we were a major trauma center. And I think the trauma part of orthopedics is what attracted to me, and that plus the sports medicine.
What exactly is sports medicine, and how does that differentiate you from a doctor who isn't a specialist in sports medicine?
Well, my training goes back to after residency. We did a lot of sports medicine in residency. Then eventually I did a sports fellowship at the Cleveland Clinic in Ohio. And what that year really is a concentration of treating not just professional athletes, but college athletes, high school athletes, and even just weekend warriors. But we did spend a lot of time covering professional and college sports and learning how to treat on-the-field injuries, and then also the stuff in the office. So you really get to spend 1 year concentrating on just all sports injuries to really hone your skills, surgically and non-surgically.
And that carries over for when people even don't have sports-related injuries, but it's kind of the same principle, right?
Yeah, I mean, you can tear let's say your rotator cuff or your ACL at work, and it's the same surgery. It's a very similar rehab. but your training and your goal is a little bit different, but it's the same type of diagnosis, sure.
As a mom, I'm very concerned about youth sports because my son's an athlete. Are you seeing an increase in sports injuries, and are there certain sports that are much more high risk than others?
Yeah, overall, there's an increase. I have 3 little athletes of my own,
Yeah.
and it's especially in Florida. There's really no off season for a lot of these kids. They play multiple sports. Some kids specialize in just one sport, and they're playing all year round and at a higher level. And they're always trying to get a higher level, and I think that leads to certainly injuries, especially if they're not resting. And some of them are playing travel baseball, rec baseball, and maybe football in the same exact season. And they're really, everybody, even a 12-year-old needs some rest, and they need some time, some downtime from sports. So we're definitely seeing more and more adult-like injuries in the young population.
Are football injuries much higher than, say, soccer injuries, or not necessarily? Is it kind of just across the board?
It's across the board. I think that some of the contact versus non-contact sports lead to different type of injuries.
Okay.
Certainly the incidence of certain things like fractures and something more traumatic in football. But it's like soccer, it's a constantly changing direction sport. The incidence of ACL tears specifically is going up and up and up, and football as well.
I was speaking to a chiropractor not too long ago, and he said that his practice is going up from the youth. And I was assuming he was talking about sports, and he said, no, it's because so many kids are sitting on their computers and hunching and bending over that they're actually having spinal, back and
neck pain.
Yes, I was blown away.
Yeah.
So, in your opinion, if you're going to risk something, probably sports is the better risk way to go. At least start getting out and about, right?
That would be good. Yeah. I mean, certainly the kids who stay at home have their other issues of injuries and stuff.
If someone out there is in pain, they're walking around in pain, and they just haven't gone to go see the ortho because in their mind they're afraid of, going through a surgery or having a surgery, should they come and see you anyway and at least talk about what some of the options are?
Yeah, I think, I'm certainly surgeon is in what I do and what we love to do, but it is not the majority. Most of us orthopedic surgeons, the majority of our treatment is going to be non-surgical, and certainly to start it's going to be non-surgical. Unfortunately, some fail those treatments, whether they're therapy or medications, injections, and get to the surgical point. But yeah, we have extensive experience, and again, the majority of our patients are non-surgical patients.
What are some of those options that someone could have if it wasn't surgery? Like, what are some of the other things that are happening right now that are non-surgical that you offer?
Well, in the field these days, we're trying to heal the human body in ways that we never could before. There are biologic enhancing treatments that people are seeking out, and we provide different types of injections, things like PRP or platelet-rich plasma.
Tell me about that, because I've read about that and I don't understand what it is.
So platelet-rich plasma is one of the biological type of treatments where we actually draw your blood, our patient's blood. There's varying techniques of centrifuge or spinning down the blood and obtaining a concentrated portion of platelets. And platelets are normally for clotting blood, but they also have growth factors, so they can stimulate growth of tendon, growth of cartilage in some situations, and really promote healing in the human body. So when we gather the platelets in an injectable form, we can put it into a knee, put it into a shoulder, and get some pretty great results. Now, we're still trying to work out the details of really, is it changing the human body, or is it just in making people feel better, or both? And I think each situation is quite different. So that's one of the many options. Things like stem cells is sort of growing in leaps and bounds, and not just in orthopedics. That's getting usually cells from bone marrow or fat or both, and injecting that as well in arthritis and tendon injuries and things that in the past we couldn't really cure or make feel better without surgery. It's just another addition in sort of our bag of tricks of what we can do for patients.
You had mentioned earlier to me when we hadn't gone on yet about the changes that are happening in orthopedics and surgeries. Can you talk to us about that? Because it sounds like there's some really great stuff happening right now.
There are surgeries like rotator cuff tears, for instance. Rotator cuff, which is the 4 tendons of the shoulder that are commonly torn in people that had no injury. It's just a wear and tear type of phenomenon.
That's not just a sports thing. It's actually because people through daily life can have those torn?
Sure. Most research shows that over the age of 60, probably 30 to 40% of patients have a rotator cuff tear and never had an injury.
Okay.
We liken it to if you wore your favorite pair of jeans every day for a year, you get that nice little hole in the front, which kids love.
Yeah.
That's what happens to our rotator cuff, that it wears down a little bit every day, and then eventually becomes symptomatic, and you show up in my office, and we sometimes see a pretty dramatically large tear, and the patient had no symptoms other than maybe a couple of weeks.
Yeah.
So the biology is changing in our body. The tendon is wearing down without our knowledge necessarily. So here we are trying to repair that tendon.
Because there's not pain that's going along. Like it's not getting more and more sore along the way. It just all of a sudden one day
It can
hurts.
be all of a sudden or just gradually creeping up. And or an injury sparks the visit to the office. And then so we've been looking for ways to take that obviously bad biology. So the tendon has been getting worse over years. The blood supply is not so great. And then it ruptures. So we've been trying to look for ways to enhance the biology. So we know how to really well sew that tendon back to the bone. But how can you make it heal? How can you give it a stimulus? So some of the times the stimulus is stem cells or PRP. We've been using these special patches in my practice. There's different ones on the market. Recently I've been introduced to one in the past year. It's a collagen patch. Our tendons are made out of collagen that you basically can implant arthroscopically, which is the way I do all of my rotator cuffs, very quickly and staple it to the tendon after you repair it.
Okay.
And it helps to stimulate healing of that tendon and maybe improve the biology, because the failure rate of some of these, especially older rotator cuff tears, actually can be quite high. So we're trying to improve the situation.
If you're going to do surgery on one side, does that normally mean the other side is going to start having problems or not necessarily?
There's been good research, especially if you have a tear in your non-dominant shoulder. There's a very high incidence of, at the same time, having a dominant shoulder tear that's not symptomatic at the time, up to 50%. So this is kind of brewing in a lot of people's bodies, but it can certainly be a normal tendon, fall down playing a sport, and then it ruptures. And those are two very different patients.
Would you recommend that if it's the non-dominant and it's likely that the dominant side is, would you just do both at once?
Surgically?
Yeah.
Well, we only treat the one that hurts.
Okay.
And I do ultrasound in my office. So ultrasound is a minimally invasive way to get instant feedback in the body, much like an OBGYN would ultrasound a baby. We can look at tendons under ultrasound, and we can do injections under ultrasound.
Okay.
So if you have a known tear, let's say on one side, I may actually put the probe on the other side. There's no risk, there's no radiation. It takes 5 minutes to get a sense, because people always ask, well, what about my other side?
Yeah.
So I can give them that feedback instantly. It may change what they do for a sport. They may adjust their lifestyle, so they don't necessarily develop pain in that tear that they didn't even know they had.
What other types of surgeries do you perform, and which ones are your favorites?
I do mostly, my practice is mostly shoulder, elbow, and knee surgery, and it's almost all, but not all, arthroscopic,
Okay.
minimally invasive. I think if I had to pick a joint that I love doing surgery on the best is shoulder.
Okay.
Recently, over the last couple of years, I've been doing more hip arthroscopies. And as you sort of introduce a new technology into your own practice, that's pretty exciting. So the hip arthroscopy world is actually exploding. And I've been sort of catching that wave and getting really interested in the hip, which from a surgical standpoint is actually very much like the shoulder, but does present sort of different problems and different pathology. So,
For an arthroscopy, compared to how surgery used to be done, can you explain those two differences for listeners who may not understand?
sure, like a surgery like, let's say, a knee replacement, it's a very large incision, everything's done open under direct visualization. But arthroscopic surgery, much like laparoscopic, which is in the abdomen, so if they take out a gallbladder these days, it's usually through a camera. We do the same thing in orthopedics. I'm basically looking at a television screen while instruments are in the joint. And so
Okay.
the benefit is less scarring, certainly. Visually it's nicer for patients because they don't have as larger incisions. But more importantly, they feel better quicker, and they form less scar tissue, which can complicate some surgeries. So the recovery can feel faster. What's going on the inside is still the same. If you repair a tendon with a big incision or arthroscopically, people have to respect that there's still biology going on, but they feel so much better when we do it arthroscopically, and certainly most people go home the same day.
Is there ever a time when somebody shouldn't have it done that way, when they should use the older style?
Well, we always tell our patients there's an option to convert. We will switch in the middle of the surgery if something can't be done arthroscopically.
Okay.
We always get consent to do it open. And open may mean a 2-inch incision. It doesn't have to be a very large incision. But patients are realistic. They understand there's certain things that can't be done that way. But most of what we do, we can access the joint. And sometimes the surgery is easier arthroscopically because you can see way more through a camera than you can with an open procedure.
I understand you're also involved in some FDA research trial.
Yeah, one of my other interests has been cartilage transplants. And cartilage, which leads to arthritis, so the cartilage is the lining of a joint, any joint. Loss of that cartilage is, by definition of arthritis, a common source of pain and a common source of frustration because really there's no cure for arthritis. So there are these sort of cures developing through technology. If you have isolated areas of cartilage loss, either from an injury, most of the time from an injury or from aging, but it hasn't quite spread throughout, let's say, the knee, we can take cartilage and transplant. So what we're doing is
Take it from other areas of the body?
Well, in the case of this surgery, it's from the patient's knee. So this is a knee FDA trial of a product called NovaCart 3D. Now, it's being used in thousands and thousands of patients already in Europe. But to do it here, you need FDA approval. So what we're doing is comparing it to one of the standard treatments for cartilage injuries called microfracture. We take a sliver of the patient's cartilage, a small amount. We send it to a lab. And then 21 days later, the patient comes back for a second surgery. And now they've given us the cells from their body. They've expanded it into a little disc made out of collagen and some other materials. And we sew that disc over the hole in their cartilage.
And it's their own cartilage
It's
at
their
this
cartilage,
point.
but nobody else's.
Oh my gosh, this is so cool.
And then basically that cartilage will fill in their own defect and hopefully cure their arthritis, make this hole have cartilage in it again. And so it's being done around the world very, very successfully. So I'm part of a trial to get it here in the United States for our patients.
When do you think that could be available in the U.S.? Is there any time frame?
Well, there's other cartilage transplantations already available in the United States. This specific type where you impregnate it into a disc, you're probably looking at several years down the road. These FDA trials take years. So we're probably looking at many more years to go, 5 years probably.
Is that frustrating for you, the time frame, or you just know that that's what it is?
Well, I think the frustration, of course, all of us is if it's being done in Europe on tens of thousands of people.
Successfully,
Americans aren't that much different than Europeans. But the FDA has their rules, and we have to follow them. So that's the only frustrating part, because we know the technology works.
Yeah.
The papers are written. You'd love to be able to just do it. So you have to meet some certain criteria to be enrolled, and you have to want to be enrolled because it is a randomized study, because you may come out of anesthesia having the control group, which is not the research arm. So people have to be able to consent for that.
I understand baseball season. I'm not very great with all sports, but I know the baseball season's coming, and I've been hearing about the Tommy John surgery. And since I'm not a huge sports fan, I don't understand what that is. Can you talk to me about that? And how did he even get its name?
Well, Tommy John, who used to pitch for the Dodgers, is the first person to have the surgery. Okay, so the name stuck for him, and it was one of those revolutionary type surgeries where the ligament on the inside of your elbow can rupture, and almost 50%, getting close to major league pitchers, have had this surgery. It's sort of epidemic-like. But back then, it was your career was over once you ruptured it. There was no good option. So it's a reconstruction, much like an ACL, where you take a piece of tendon from somewhere and reconstruct the inside of the elbow. And it has a very high success rate. It's a long recovery. But the Tommy John procedure has undergone some changes and some modifications, but the main surgery is still the same, is to reconstruct that, what we call the ulnar collateral ligament of the elbow, which has, and in tennis players too, sees a lot of tension in overhead athletes in general.
For tennis elbow, because you're doing the whole tennis thing, what is the first step in treating that?
Tennis elbow. So tennis elbow doesn't occur in most tennis players, or rephrase that, most people come to the office who have tennis elbow don't play tennis. It's from overuse, but it was discovered in tennis players, and it's kind of one of those mixed bag of problems, but it's really a tendon problem. The extensor tendon on the outside of your elbow becomes exquisitely painful. So the treatment depends on how long it's been there. So if it's been there only a couple of weeks, we do some things different than if it's been there 6 months, 9 months. It's kind of like micro tears in the tendon. It doesn't completely rupture, and it's exquisitely painful. But things like the PRP, as we talked about before, has a very high success rate in avoiding surgery. 1 or 2 of those shots works about 85% of the time. And then we do some minimally invasive surgical techniques for a very small percentage of patients when it's just not working.
When patients are looking for an orthopedic surgeon or a sports medicine specialist, what should they look for and what questions should they be asking? I mean, how do you identify a good one?
Well, I think I'm a good one, so that's good.
Perfect.
It goes back to looking for a doctor in general. I think that everyone sort of has the things they're looking for, obviously background training, surgical skills. I think for sports injuries, there's a depth of knowledge that not everyone has, and the compassion to sit and listen, because there's a lot going on, especially in the youth sports, even if they're approaching college. There's a lot going on in what's happening in-season injuries, out-of-season injuries, how many sports they play. So you really have to be able to be a good listener, I think, to take care of sports injuries. There's a lot of psychology to it, and there's a lot of other people involved sometimes, if they're athletes, parents, agents, you choose. But sports, especially down here in Florida, it's very passionate. I mean, I always joke that I've saved many people's lives, because I have patients who tell me, if I can't play golf 5 times a week, I'm going to, quote unquote, kill myself. And
They say
so
that?
they do say that. So sports has become so big in our lives. I mean, there are people in their 80s, out there playing golf, tennis, running marathons. It used to stop, 50s, 60s, you were done. It's not that way anymore. It's from cradle to grave. And so I think you have to be really good at adjusting, looking at who's in front of you, the age of the patient, and what their goals, and don't right off the bat say to a 75-year-old, I really think you should stop. Because it's not reasonable anymore. Because that's what the old teaching was. Well, you're too old. You're too old to have your ACL done at 50. Well, that's not really true anymore. Because if you're a 50-year-old high-level tennis player 5 days a week, you're not playing tennis without ACL surgery. And so some of my mentors, I've been in their offices when I was a younger resident, they would just say, well, you're too old to do that. Stop. And we don't do that anymore. Marathon runners, CrossFitters in their 60s, times have changed. And you have to be willing to not tell them to give up and help them in the best way we can.
So because you're a surgeon, do you play sports? Or does that scare you what you do? What sports do you play?
I certainly gravitated towards safer sports.
Okay.
I tore my ACL playing basketball a long, long time ago, so
Yeah.
I don't play organized basketball anymore. I play with my son, but I play tennis mostly and golf. I wish I played more, but tennis is probably my most favorite sport to play.
Do you do anything else on your downtime?
What we were talking about before, I'm trying to get back into drumming. As a youth, I played in a lot of bands and things like that. So we have a studio nearby that we've gone to recently and started playing again. So it's one of those hobbies you can do anytime. Nighttime we go there at 11 o'clock at night sometimes to jam and just blow off some steam. So getting back into drumming is something I really want to do.
Very, very cool. How many people are in your band?
It depends who shows up. 3 or 4 guys so far,
Okay.
and it's really just real informal right now. We'll see where it goes.
You have a singer?
We do have a singer.
All right.
Yeah, he used to play with Tom Petty. He's actually really good.
I'm impressed.
No female singer, so if you sing and you want to come, give us a shout.
Practice.
But yeah, it's fun. It's really fun.
So only because I've done this, do you ever go to drum circles?
Drum circles? No.
Drum circles are fun.
Never
There's something
been.
you could definitely, because you can just bring your little drum out and you jam with a whole bunch of people.
Oh, really?
And they have them in Delray often, so I didn't
Okay.
know if you were able to check one of those
I'll look it
up. Names for your band?
The one I came up with is called Surgical Exposure. We'll see if that sticks. It's all surgical people in the band, so we figured that would be good.
You mentioned that your kids are playing sports right now. What are they doing?
My son plays golf and basketball.
Okay.
One of my daughters is a full-time dancer every night. A lot of travel and competitive dancer. And my
Yeah.
oldest daughter plays travel soccer.
We are in travel soccer as well. And it's interesting because a lot of the families do have the daughters that are in dance and then the boys that are in travel soccer. And it's the dancers that are always walking up with the sports injuries. Like almost always. Have you noticed that, like with your daughter?
Yeah, and they have a lot of overuse. I mean, she dances almost every day of the week and then weekends. She's had a stress fracture in her foot. So the pounding of the hard dance floor, leads to fractures.
Yeah.
They do have traumatic injuries when they're trying a new move and they jump up in the air and don't land the way they wanted to. And I've seen those. I've been at the studio to pick her up and someone comes to get me because somebody dislocates a kneecap. So It's a sport.
It's a sport. It's a real sport.
It's
It's
a
no
real
joke
sport,
sport.
and they're not just performing; they're competing now,
Uh-huh.
which makes it, that high level. So they're really practicing hard. It's not just the recitals and the flowers anymore. It's a
Yeah.
big competition.
And same for gymnasts as well, right?
Yeah, and the gymnasts,
That's a whole other-
hours and hours of dedication, very technically challenged. Probably the highest rate of the worst injuries, really. Some of them are
That's what I
life-threatening. So I used to cover gymnastic events when I was a fellow
Mm-hmm.
in Cleveland and did not like it because the potential was there for something catastrophic. Same thing with cheerleading. It's a very uncomfortable feeling when you're at a cheerleading event and one of the girls is 20 feet in the air doing flips and you're just sort of waiting. Everyone else is applauding and I'm just waiting for something to happen.
Oh, gosh.
So luckily I've never seen anything that terrible, but it's good.
For young girls that are in gymnastics, that pounding that they're constantly taking on their body, does that affect growth?
It does, and most of them are starting very young, and their growth plates, where we grow from, get injured. They get a lot of growth plate problems, stress fractures of growth plates, injuries of growth plates that sometimes don't even show up in an x-ray, but they're very, very painful. So as their bodies are trying to develop, they're doing very high-level athletics. They're very strong, but they're tiny, usually tiny little kids.
Yeah.
And they're working all morning and after school all night. And it's a lot. It's a lot. To do the technical things that they have to do at a high level takes hours and hours of practice. It really does.
For anyone that wants to get in touch with you after the show, who might be looking to talk to an orthopedic surgeon, what's the best way to reach you?
Our office number is 561-417-3339. Also on the web, you can look us up, even make an appointment at HershMD.com. Hersh is spelled HERSCHMD.com.
Perfect. And just before we leave, what are the best things people can be doing to stay in shape and keep their bones and ligaments healthy? What do you recommend?
Well, staying active, and that can mean anything from just walking 30 minutes a day, riding a bike. I really think you have to be in tune with what your body's capable of doing and not really overdoing it.
Diet?
Diet's huge. I think that a well-balanced diet, avoiding the fast foods of America as much as you possibly can, and really, even packing food. And one of the things that I've learned how to do is prepare food before going to work, and I think that's made a huge difference in my life.
Why is that? Because it stopped you from ending up at fast food?
It does, and it controls your portions as well. I think we, as a whole in America, our portions are way too large.
Yeah.
So you can really control your portions if you make it ahead of time, how many times you eat a day and what you eat. You have a lot more control over it.
Well, Dr. Hersh, it's been a pleasure speaking with you and learning from you. Please come and visit us again soon. Listeners, remember to join us every Monday from 7 to 8 p.m. on WWNN 1470 AM and to stay abreast of the latest of happenings in medicine. This is Dana Hammill, and I'll see you next week.
Thanks for listening and watching Stayin' Alive with Dana Hammill. Please join us next week when Dana brings another professional in the medical community who will tell us what they are currently working on to improve your quality of life. Follow Dana on Facebook at Stayin' Alive with Dana Hammill or visit her website, www.stayinalivewithdanahammill.tv. See you next week, and may you stay healthy. The opinions expressed on the